So hello guys, welcome to podcast Med. So in this video, I'm going to be talking about physiological changes during the pregnancy. So before starting it, this is the first podcast that I'm recording on theoretical obstetrics. So for a brief introduction, I want to say how I am going to do it. So as I read D.C. Datta textbook from obstetrics, I'm going to record the audio notes from it so that I can refer to it in the future, and as well which can help the people listening to this podcast. And here it goes like this. So coming to the changes in the genital organs, we have vulva, vagina, uterus, cervix and isthmus in this. So coming to vulval changes, there is edematous and vascular changes seen in the vulva. There is increased vascular supply basically. So coming to the vagina, there is increased blood supply into the vagina, and because of the increased blood supply, there is bluish discoloration of the vaginal tissue, which can be elicited as Jacquemer sign or Chadwick sign during the pregnancy. And also, high estrogen levels during the pregnancy will stimulate lactobacillus to convert glycogen into lactic acid. It will normally do this, but because of the higher estrogen levels, this will happen more prominently, and there is decreased pH, and which makes the pH of vagina or reproductive system more acidic, which prevents the infections. Coming to the cytology during the pregnancy in vagina, there are more navicular cells seen. And then coming to the uterus, the weight of uterus is normally approximately 60 grams, and during the pregnancy, during the peaks of pregnancy, it can reach up to 900 to 1000 grams. And normal length of uterus is 7.5 centimeters, which can grow till 35 centimeters in the pregnancy. And coming to the body of uterus, there is hypertrophy and hyperplasia of body seen, and there is marked spiraling of arteries in the uterine fundus, and there is enlargement of fundus, which is more than body of uterus. Coming to the muscle fibers in the uterus, there are three kinds of muscle fibers here: outer longitudinal, inner circular, intermediate muscle fibers. So these muscle fibers are arranged in a pattern which forms a kind of structure which resembles a living ligature. So it is called living ligature. Means there is occlusion of blood vessels running through the fibers when these muscles contract. So it is called living ligature. And coming to the other things that happen, uterine artery diameter will double in this pregnancy, and the blood flow in the uterine artery will increase eightfold in the pregnancy. And then coming to the shape of uterus, normally in a non-pregnant woman, it is pyriform shaped. Okay. Then at 12 weeks of pregnancy, approximately it will change to globular shape. At 28 weeks of pregnancy, it changes to ovoid shape, and 36 weeks of pregnancy, it changes to spherical shape. And other things that we see in pregnancy in the uterus are Braxton Hicks contractions, where these are irregular, infrequent, spasmodic, and painless contractions. These contractions are not felt by the patient. Patient is not conscious of it. So then coming to the isthmus. Isthmus is the area between histological and anatomical os of uterus. So it becomes more softer and it gets incorporated into the uterine cavity. And sphincteric action of circular muscles present in the isthmus will prevent abortion, like expulsion of fetus in a way. But if this sphincteric action of circular muscles is not perfectly done, then there can be chances of mid-trimester abortion, which can be corrected by encirclage operation, as we will study about it in the further chapters. And coming to the changes in cervix, there is progesterone increase in the pregnancy. So this will lead to cervical epithelial secretion, which will form a mucus plaque, and it will prevent expulsion of the fetus outside. Like expulsion of contents at least of the fetus outside. And coming to the other things, vaginal microbiome normally contains lactobacillus and also other pro-inflammatory cytokines, but this lactobacillus is anti-inflammatory. That is, we already saw that it changes the glycogen into lactic acid and produces a acidic pH, which will resist infections and inflammation. So it is anti-inflammatory. So also it protects against the pro-inflammatory cytokines in the pregnancy. And coming to the cervix, there is softening of cervix due to hypertrophy and hyperplasia. As we studied this, it's softening of everything, like cervix is softened, isthmus is softened, etc. And this softening of cervix due to hypertrophy and hyperplasia is Goodell's sign. This is a sign of one of the sign of pregnancy that is illustrated by the obstetrician. There may be ectopy and erosions of cervix, and sometimes there is squamous cells hyperactivity, which will stimulate basal cell hyperplasia, which is similar to cervical intraepithelial neoplasia. It will simulate it, okay. And coming to corpus luteum, normally it will maintain pregnancy by secreting the hormones like progesterone and estrogen before placenta takes up the action by producing HCG, HPL. If this is an excess, then we can see luteoma in pregnancy. So these are the changes in genital organs that we see. This is it with the genital organs. Now, coming to the changes in breast, the changes in breast are best evident in gravida, that is the person or a female who is pregnant for the first time. And the changes that are as follows. There is marked hypertrophy and proliferation of ducts because of estrogen stimulation, and the alveoli hypertrophy and like alveoli proliferation due to both the estrogen and progesterone action. And there is enlargement of axillary tail, and there is pain in the axillary tail observed. This may be the evidence of striation due to stretching of the cutis. And the nipples become larger, erectile, and deeply pigmented, and the sebaceous glands in the nipple will become hypertrophied, and this hypertrophied sebaceous gland in the nipple or areola region are called Montgomery's tubercles. This is one of the most common observation during the pregnancy. And outer zone of less marked and an outer zone of less marked and irregular pigmented area appears in second trimester is called secondary areola. There is secondary areola formation. And coming to the secretions, the demonstration of secretion from the breast of a woman who has never lactated is an important sign of pregnancy. Okay, this is it. And coming to the mouth, there might be sometimes increased salivation, which might be a complication in pregnancy. And sleep, there is complaints of snoring, upper airway obstruction, and obstructive sleep apnea. These are important ones, and this might be the risk factors, higher risk factors for intrauterine growth retardation, gestational hypertension via endothelial dysfunction. Like, why will this happen? Intrauterine growth retardation, why will this happen? So they said the obstructive sleep apnea means there is decreased respiratory air, right? Like breathing is problematic here. So when breathing is problematic here, there might be chances of hypoxia. Hypoxia can restrict the growth of the fetus because of oxygen deficit. And that is it for that. And coming to the cutaneous changes, on the face we can see chloasma gravidarum or pregnancy mask. It is extreme form of pigmentation around the cheek, forehead, and around the eyes. Okay. Now coming to the abdomen, there is linea nigra seen. It is brownish black pigmented area in the midline stretching from xiphi sternum to symphysis pubis. This is due to melanocyte stimulating hormone from anterior pituitary. Coming to the other changes in abdomen, there is linea nigra and there is stria gravidarum. These are slightly depressed linear marks with varying length and breadth found in pregnancy. These stretch marks will normally refer to scar tissues in the deeper layers in the cutis, and after the pregnancy these will become whitened and glistening white. It will become glistening white, and this appearance is called stria albicans. Okay, the other cutaneous changes may be vascular spider or palmar erythema, which are due to high estrogen levels. Coming to the weight gain in the pregnancy, a singleton pregnancy for a healthy woman, like singleton means a single baby inside the womb, for a healthy woman averages up to 11 to 12 kgs, so she might be gaining 11 to 12 kgs approximately. So 60% of the total weight gain is because of combined weight of fetus, placenta and amniotic fluid. The other is might be due to hemodilution. And coming to the pregnancy weight gain recommendations, the ideal weight gain during the pregnancy depends on the pre-pregnancy BMI of the woman. Like if the pregnancy BMI is between normal weight, that is 18.5 to 24.9, ideal BMI weight, there should be gain of 25 to 35 lb of weight, that is approximately. And the importance of weight checking, it is because of if there is rapid weight gain in the pregnancy, it can be the early manifestation of preeclampsia, and we have to be careful about it. And coming to the stationary or falling weight, if the woman is not gaining any weight, or if the woman is losing weight, it might be due to intrauterine growth retardation or intrauterine death of the fetus. That is about it. That is about the weight gain during the pregnancy. Coming to the body water metabolism, water retained at the term is 6.5 liters approximately. Okay, this water content, fetus, placenta and amniotic fluid contributes to 3.5 liters of it. The remaining is because of retention of retention of the fluid in the body. The causes of sodium retention and volume overload are as follows. That is changes in maternal osmoregulation. It can be due to maternal osmoregulation changes, increased estrogen and progesterone obviously, and increased in RAS activity, that is renin, angiotensin and aldosterone system activity. And it can also be due to increased aldosterone deoxycorticosterone. And it can be it can be due to control by ADH from posterior pituitary, and it can also be due to ANP, that is atrial natriuretic peptide. Basically, there is resetting of osmotic thresholds for thirst and ADH secretion. Increase in water intake due to lowered osmotic threshold for thirst causes polyuria in early pregnancy. Okay. Then coming to the hematological changes in the pregnancy, we see there is increased blood volume. Obviously, we see there is increased blood volume. That is a maximum of 40 to 50% above the non-pregnant woman level at 30 to 34 weeks. There is this much of gain, Anumat. Then coming to the increase in plasma levels, there is a maximum extent of 50% of plasma levels are increased. Total plasma volume increase can be till 1.25 liters. And then coming to RBC and hemoglobin, RBC is increased to 20 to 30%. Because of this difference between plasma increase and RBC increase, there is more increase in plasma, that is 50%. Coming to RBC, it is increasing only by 20 to 30%. So there is relative hemodilution here. The plasma, even though RBCs are not less, because of more increase in plasma than RBC levels, there is relative hemodilution. And Because of this relative hemodilution, there are few advantages to the pregnant woman and fetus as well. This will favor as first one, that is diminished blood viscosity ensures optimum gaseous exchange between mater and fetal circulation. So there will be, obviously it is thin fluid, the oxygen exchange can happen very easily, and it protects the woman against the adverse effects of supine and erect posture. You know what happens during the supine posture and erect posture of women? Like if the woman is in supine position, the high so in this supine position, the gravid uterus, that is gravid uterus produces a compression effect on inferior vena cava when she lies down in the supine position. But normally, when this happens, there will be collateral circulation formed. But in some cases, like 10% of the cases, collateral circulation fails to open up. So then it will be problematic, and venous return of the heart may be seriously uh, abnormal, and this results in the production of hypotension, tachycardia, and syncope. This will be reversed just by turning the patient to the lateral position. Okay, this is about the supine position, supine posture. So this hemodilution also protects the woman through that adverse effects of supine and erect postures, and it also protects the mother against the adverse effects of blood loss during the pregnancy. Even though there is a lot of blood loss, because the RBCs are relatively less in the plasma levels, there might be, I think so, it might be because of that. RBC levels are less, even the blood is lost, more RBC is not lost. So like that, relatively RBC loss is less compared to the non-pregnant women. Coming to the leukocytes and immune system, there is neutrophilic leukocytosis due to raised levels of estrogen and cortisol, obviously. And the major shift is between cell-mediated cytotoxic immune response to, it will shift to humoral and innate immune responses. And coming to total protein levels, okay, total protein increases, plasma protein concentration will decrease too. And coming to the albumin levels, that is decreased by 30%. It is so much decreased compared to all the other proteins. So we can say this might also be the cause for edema, increased pedal edema in the pregnancies. And yes, sir, that is erythrocyte sedimentation rate is increased fourfold during the pregnancy, and there can be gestational thrombocytopenia. What happens here is when there is hemodilution, there is RBC increase, and relative to plasma increase. What I was saying is there is RBC increase and plasma increase, but plasma increase is more than RBC increase. So there is relative hemodilution here. Okay, so bone marrow thinks there is less RBC in the body, so will produce more RBC. So there is erythroid hyperplasia, and all the other contents of the bone marrow are suppressed, like lymphoid and platelet megakaryocyte precursors are suppressed here. So because of that, there is thrombocytopenia observed. So this is all about, and also level of coagulation factors will increase, like the pregnancy itself is a hypercoagulable state, so there is increased level of coagulation factors, but this will become normal 2 weeks after the delivery. So coming to the cardiovascular changes in the pregnancy, normally anatomically heart is pushed upwards and outwards during the pregnancy, and it will be rotated slightly towards the left also. And coming to the abnormal clinical findings, there is apex beat, which is shifted from fourth intercostal space about 2.5 centimeter outside the mid-clavicular line, and there is a systolic murmur which is audible in apical or pulmonary area, and this is due to decreased blood viscosity and torsion of great vessels. And there can be continuous hissing murmur, that is called mammary murmur, because it is heard over the tricuspid area in the left, second, and third intercostal spaces. This is due to increased blood flow through internal memory vessels. So it is called memory murmur, as the name suggests. And there is increased left ventricular end diastolic diameters. The left and right atrial diameters also increased. A third heart sound due to rapid diastolic filling is heard. And the changes in the normal cardiac sounds are, first there is splitting of first sound, and there are no changes in the second sound. Third sound is loud, as I said. And there is increased cardiac output, obviously because of hemodilution and increased volume, blood volume. And here is they gave one point here that I'm going to read it out. There is squeezing out of blood from the uterus into the maternal circulation. This is called autotransfusion during the labor and in the immediate postpartum. Okay. And then now coming to the other things, blood pressure. There is overall decrease in the diastolic blood pressure and mean arterial pressure by 5 to 10 mmHg in mid-pregnancy. And coming to the venous pressure, antecubital venous pressure is normal, like it is unaffected, but femoral venous pressure is markedly raised because pressure is exerted by the gravid uterus on the common iliac veins, and it is more on the right side due to dextrorotation of the uterus. This also explains that physiological edema of the pregnancy subsides by rest alone. Then coming to the central hemodynamics, that is, they gave here about supine hypotension syndrome, that is postural hypotension. I already have said about it. And then here we can see regional distribution of blood flow. There is increased pulmonary blood flow, renal blood flow, etc. And there is increased blood flow through the skin and mucous membranes as well, and it reaches to maximum of 500 ml per minute by 36th week. And this can be explained. This explains the heat sensation, sweating or stuffy nose complained by the pregnant women normally, because it is due to increased blood flow to the skin and mucous membranes. And coming to the metabolic changes in the pregnancy, there is positive nitrogen balance throughout the pregnancy. That is, breakdown of amino acids to urea is suppressed and the blood urea levels falls in this. So this is positive nitrogenous balance. Coming to the carbohydrate metabolism here, plasma insulin level is increased due to number of contra-insulin factors like estrogen, progesterone, human placental lactogen, cortisol, prolactin, free fatty acids, leptin, and tumor necrosis factor alpha, TNF alpha. All of these will favor the increased levels of insulin. And even though there is increased levels of insulin, there is insulin resistance observed. Okay. Coming to the insulin resistance observed, so increased insulin levels also favors lipogenesis, that is fat storage. So women will store more fat and gain more weight also because of this. And coming to the lipid metabolism, HDL level increases by 15%. LDL is utilized by placental steroid synthesis. So even though there is hyperlipidemia in normal pregnancy, it is not atherogenic. So it is because the cholesterol that is present in the body is utilized by the placenta for placental steroid synthesis. And coming to the iron metabolism, total iron requirement during the pregnancy is approximately 1000 mg. This mainly happens in the last trimester. Placenta also transfers adequate iron to the fetus. So even though there is severe maternal iron deficiency, this will not affect fetus anymore. Then coming to the systemic changes, the respiratory system. There is increased subcostal angle, transverse diameter of the chest expands, chest circumference increases, a state of hyperventilation occurs during the pregnancy, and there is increased tidal volume. It might be due to progesterone, which acts on respiratory center, and also increase in sensitivity of the center to carbon dioxide. So the woman feels shortness of breath. And then there is a pH rise in the pregnancy in order of 0.02 units. So pregnancy is in the state of respiratory alkalosis. So by this we can say pregnancy is a state of respiratory alkalosis. And then coming to the urinary system, there is dilatation of ureters, renal pelvis, and calyces. Kidneys also enlarged by 1 centimeter. And ureters become atonic due to high progesterone levels. Because of this, there might be stasis, which is marked between 20 to 24 weeks. There is elongation, kinking, and outward displacement of the uterus. Okay, and coming to the bladder, there is marked congestion and hypertrophy of muscles and elastic tissues. All of this might be because of the pressure by the gravid uterus. Okay, and in the first, increased frequency of micturition is first seen in 6 to 8 weeks of pregnancy, which will subside by 12 weeks. This increased frequency of micturition is due to resetting of osmoregulation causing increased water intake and polyuria. And then in the late pregnancy, there is stress incontinence due to urethral sphincter weakness because of increased pressure over it by the gravid uterus. Coming to the alimentary canal, this is so interesting. Muscle tone and motility of the entire GIT, that is gastrointestinal tract, or diminished. It is due to high progesterone levels. Okay, so because of this, there is constipation and gastroparesis kind of condition. So when contents are not pushed out immediately, there is more absorption of nutrients and more supply of nutrients to the fetus. And coming to the liver and gallbladder, there is only rise in alkaline phosphatase levels, and other liver function tests are normal. And there might be mild cholestasis, which is estrogen effect, and marked atonicity of gallbladder, which is progesterone effect. This can be a risk factor for stone formation with high blood cholesterol levels in the woman. Coming to the nervous system, में हम postpartum blues, depression, or psychosis may develop in susceptible individuals. Postpartum psychosis. Okay, then coming to, there might be carpal tunnel syndrome because of the compression of median nerve, and there might be compression of lateral cutaneous nerve of thigh as well. And then coming to the calcium metabolism skeletal system, there is increased mobility of the pelvic joints due to softening of ligaments caused mainly by hormone. This, along with increased lumbar lordosis during later months of pregnancy due to enlarged uterus, produces backache and waddling gait. Basically, there is lumbar lordosis, backache, and waddling gait, and there is increased mobility of pelvic joints due to ligament softening. And I think this is it for this podcast, that is physiological changes during the pregnancy. So we have completed it. Finally, we have discussed about genital organs, changes in the genital organs, changes in the breast, cutaneous changes, weight gain in pregnancy, body water metabolism, hematological changes, cardiovascular system changes, metabolic changes, systemic changes, respiratory, maybe urinary, alimentary system, liver, gallbladder, nervous system, etc. So here we go. We are done with physiological changes during pregnancy.